Okay, good morning, everyone, and I'm here to talk about selection and use of the non-TNF biological therapies, who, when, and how. And so right now in July of 2015, really the drugs that we have available to us in terms of a non-anti-TNF biologic is vedolizumab, or Entyvio. There's another one that's already out on the market, used to Kinyuen Lab, which is available for psoriasis, which is the only non-anti-TNF biologic, so you might be able to get your hands on it. Janssen, in fact, has been very generous, and I'll say a few words at the end about it, in terms of offering it as a compassionate use drug, not based upon disease activity, interestingly enough, but based upon financial needs. So I'll say a few words about that, but that's not approved for Crohn's disease. The pivotal trials are just about completed, so we'll hear more about that for sure in the next couple of years. So we're going to speak about its use in ulcerative colitis and Crohn's, and I'm going to focus basically the vast majority of this talk on vedolizumab. And so we'll say, well, we have these anti-TNFs, which really are now available for the last 17 years. These are not new drugs. And the anti-TNFs, we all recognize, have revolutionized our treatment in IBD, and I think all of us for both ulcerative colitis and Crohn's disease recognize their utility and how much they've helped our patients. But if you think about it, and from the randomized controlled trials, and that's what we're going to compare into the vedolizumab era now, before we talk about a little bit of open label experience with vedolizumab, the clinical remission rates with both infliximab and ulcerative colitis and in Crohn's disease are not really that striking. If you look at what I would submit to you is probably the best in terms of results, clinical trials in ulcerative colitis, with infliximab at week 8, you have about a 40% remission rate with infliximab. That's after 3 doses, 0, 2, and 6 weeks. And at sustained remission out to week 54, obviously week 8 remission is not what we're ultimately looking for. We're looking for 1 year, 2 year, 3 year. We're down to about 20%. That's a number I think we should keep in mind when we look at the vedolizumab data. Yeah, in private practice, I think we all do much better than that. That's because we can give patients combination therapy. We can add perhaps a short course of steroids. But we're going to look at the controlled trials of vedolizumab. These are what we're going to compare to as the randomized controlled trials we have for the anti-TNFs. How about for Crohn's disease? Are the anti-TNFs a home run here? Well, we think in real practice, again, it's revolutionized therapy, but how do we really do in the controlled trials? Well, 40% of patients don't have improvement in their symptoms with early use, 60% do. And when you follow these patients for up to a year in terms of steroid-free remission, you're only looking at about 30% of patients are at a steroid-free remission. So these are not grand slams in terms of randomized controlled trials. In clinical practice, yes, we all do better, but we're going to look at the vedolizumab controlled trial, so this is our basis of comparison. So what is vedolizumab? This is CME, so we're not going to talk using brand names, but just so you recognize what this drug is, it's Entyvio. It was approved last May, so now there's about 15 months of experience, and from last count, I'm told 15,000 patients have received it, and with the clinical trials, there have been a fraction, 4,000 perhaps, who have gotten it for at least 2 years for a safety database. So this is actually what I would call a gut-selective drug, which will enhance its use because of its really what I think is a remarkable safety profile. And it's a very simple, direct, elegant mechanism of action in that you have T cells that are activated in the lamina propria, and before they leave the lamina propria, they are labeled with these small GPS antennas. They then leave the lamina propria, enter the circulation, and are circulating throughout the entire body, looking for its specific receptor. And how do I reverse? And that specific receptor. Okay, great. So the specific receptor for it is MADCAM. MADCAM is only located in the small and large bowel. So this activated T cell labeled with alpha-4 beta-7 is circulating through the lungs, circulating through the liver, circulating through the kidney, and it's looking for MADCAM. But MADCAM is only localized in the small and large bowel, and when it finds the MADCAM, it's been flying through all the circulation. It slowly stops rolling as fast. It gets tethered. It binds to MADCAM, as you see here, and when it binds to MADCAM, it can enter the lamina propria, where it induces all the inflammation. That's the hallmark of ulcerative colitis and Crohn's. So it's gut selective. So what are the results from the randomized controlled trials? These have obviously been fully published, both of them in the New England Journal of Medicine and in Gastro for ulcerative colitis and Crohn's. So what are the trial design? And I'm not going to focus on this too much, only to make a point about how we have to interpret these trials in terms of one-year outcomes. And that is that in terms of the study design, the outcome, the primary outcome was at week 6. So patients were treated with the drug or given open label drug or placebo, and the primary outcome was at week 6. Week 6 responders were then re-randomized to get either Q4 week 300 milligrams or Q8 week 300 milligrams. And as you'll see repeatedly in the UC and Crohn's trials, there was no difference between Q4 and Q8, which led to the approval of Q8. And if you want to step up, as we do in anti-TNF in terms of more frequent dosing, it's going to be exquisitely difficult because this is an expensive drug and the insurers aren't going to let you double the dose by going to Q4 weeks. I'll just make that point now. So how did the patients do? Now remember, anything you see for 52-week outcomes is based upon those patients who already had responded at week 6, and patients had to come off steroids. So these are the response. Clinical response and remission at week 6. The primary outcome, again, was the clinical response at week 6. And in terms of looking at patients without anti-TNF exposure, so let's compare it to the patients in the anti-TNF studies, who obviously were not on anti-TNFs beforehand, clinical response in about half of patients. And in patients who had had a prior anti-TNF failure, a more refractory, more resistant group, you had obviously a lower percentage, 39%, and if you looked at both combined groups, it was about 50%. So keep that number in mind, because when we look at maintenance, those patients going to have a response to these patients who are at week 6 responders. And so what do you see at week 52? When you look at patients without anti-TNF exposure previously, you'll see there's about a 40% or up to 50%, no difference between Q4 and Q8 week. And then again, you have to multiply this by about the 50% 6-week clinical response rate. If you look at the patients who did have prior anti-TNF exposure, the more refractory group, it's a little lower, it's at 40%. But these reach statistical significance. But again, you have to remember that this was a function of who responded at week 6. In terms of a more stringent criteria, steroid-free clinical remission, and obviously there's no meaning to have a remission at week 52 if the patient's on steroids. That's not remotely a satisfactory outcome. So here you had 31%, again, of the 50% response group compared to 14%, and this was statistically significant. So let me just put this in context, an interesting little anecdote. Dave Rubin and I, a year ago, actually, in January of 2014, the FDA GI Advisory Committee had a day-long meeting where Takeda presents their data to the advisory committee. And then the FDA has a list of questions that they've outlined that at the end of the day have to vote based upon the data that's presented to them. So this was in January. So the night before, there had been a little bit of ice on the ground. And I think everyone here in Chicago, when it's cold, goes to work. In Washington, D.C., they don't go to work. If someone in Washington, D.C. says, no, we're staying home today because there's a little bit of ice on the ground. Bethesda is where the FDA is. It's considered a federal agency. They couldn't start the presentation. Takeda's been building up this program for 15 years, has been planning the presentation probably for years, and they're supposed to start at 8 a.m. Everyone is in the room. Everyone flew in the night before. The government says you cannot start your presentation because Washington, D.C., the federal government, is closed down. Takeda's panicking. 8:15 can't open. 8:30 can't open. 9 o'clock can't open. They have to be done by 5 o'clock. Takeda is panicking. Finally, at 10 a.m., they said, okay, you can start your presentations. And after knowing this data, because the FDA Advisory Committee has seen it before, they said, you know what, your data is so strong for UC, it's a given. You have it. It's in the bag. We're approving UC for induction and maintenance. Takeda was going crazy. They were high-fiving each other. This is great. But now they have to figure out how to present all their data with Crohn's disease in that abbreviated patch. And Bruce Sands, who was very quick on his feet and obviously a brilliant guy besides, figured out on the fly that how to present the Crohn's disease data in the most efficient way. And it was a challenge because you'll see here that the Crohn's data was nowhere near as strong. You had the same endpoints. Week 6 responders were the primary endpoint, and then they got randomized to either 300 Q4 or 300 Q8, and looking at to the week 52 maintenance study. And you'll see that there was really an unimpressive, not statistically significant difference in patients at week 6, which was the primary endpoint, which didn't reach statistical significance. Obviously, patients who were anti-TNF naive did a little better, but they did not hit statistical significance. And this was really a great concern to everyone in the room in terms of looking for this drug for Crohn's disease. Though, looking out at 52 weeks, when you take that 15% response rate at the 6-week response rate of about 15, you do see a statistical significant difference at maintenance. And as with natalizumab, another anti-integrin antibody, it takes a longer time for the anti-integrins to work, and they do seem to be more effective as maintenance drugs rather than induction drugs. Statistically significant high rate of steroid-free remission, again, the only real meaningful endpoints in clinical trials, especially at week 52. So during the day, during the Crohn's disease presentation, there was a guy on the committee who was the most obnoxious, I can't use my usual vulgar descriptions, most obnoxious, annoying, I really need to use words I can't use here, impossible. Every time something was presented, he would try and crush the data. And it was clear when they came to vote, he was going to crush it, based upon you can't approve a drug for maintenance if you can't show efficacy for induction. Doesn't make sense. And so in the afternoon, there's something known as the open public hearing, and David gave a 4-minute presentation. I gave a 4-minute presentation. Before we got up, though, they invited several patients, and they were basically, the two that I remember most vividly were David's patients from this area, and they were going to give a 4-minute history as well. And I said, oh man, I'm so cynical, I gotta wait and hear these patients give their stories. Oh man, First patient gets up, she says, I am a University of Chicago, Dave might correct me if I sort of, a little fuzzy about the details. She said, I'm a University of Chicago resident, and I was on TPN. I used to make rounds at night with my IV pole because I couldn't eat because my Crohn's was so severe until I got onto one of the vedolizumab trials, and it changed my life with Crohn's disease. Very impressive. The next patient, and sometimes I get choked up when I talk about this next patient, there's a patient gets up, blue-collar woman, somewhere from probably further out than Chicago, and she says, I've been sick with Crohn's disease for all my years. I have a 5-year-old daughter, and I couldn't take care of her until I got into the vedolizumab trials for Crohn's disease. And when I knew I was coming down here, my daughter said to me last night, she said, please, Mommy, don't let them take you away from me again. I said, whoa. And that, I thought, is going to have some impact, but not on that one guy. I thought he's going to be impossible to sway. So what happens? In the afternoon, they have to vote. And what happens? So they go around the table, and this is not what they're voting on, the fistula. They go around the table, and when it comes to this one guy, I said, this guy's going to be so vocal, he's just going to crush everybody else's vote. And he says, you know what? I know we need to have 2 positive trials to approve a drug, or 1 overwhelmingly positive trial in Crohn's disease here, and we have neither one. But I recognize now, listening to these stories, the unmet need, and I vote for approval. And I think that comment carried the day. And I think he swayed enough people that the FDA ultimately, the advisory board, ultimately approved the drug and led to the FDA approval for both UC and Crohn's on the same day last May. So the patient stories carried the day. Now, how about another important endpoint, another important unmet need in patients with Crohn's disease? And that is patients who have not gotten better, say, with anti-TNFs for their fistula, or have not been treated with an anti-TNF for the fistula. So patients in the Crohn's disease studies who had fistula were not excluded from the study. So we do have data to look back in a post hoc analysis and see, in fact, does vedolizumab help close fistula? And in fact, there were a relatively small number of patients, 57% of patients, and they were able to look at the patients treated with vedolizumab versus, in blue, patients treated with placebo. And patients treated with active drug, by about a month, you started to see fistula closure in about a third of patients compared to 11% of placebo, and this was sustained very nicely out to week 52. So if you do have a patient, I wouldn't say jump to vedolizumab as your first-line therapy for fistula closure, but if you have an anti-TNF failure and you're worried that you're going to put the patient on a vedolizumab and you have to abandon success for fistula closure, that's not the case. Now, what is probably the most enticing, attractive use of vedolizumab in our patients, both UC and Crohn's disease? And it is because it is gut selective, we find out that it really carries through in terms of having really what I think is a remarkably excellent safety profile. We'll see it in several looks at it. Vedolizumab in UC trials, in overall the placebo and vedolizumab, whether it was Q8 weeks or Q4 weeks, there's no differences in terms of serious adverse events. And in fact, you look down in discontinuation of therapy, and in fact, it was more frequently in placebo, and that's in large part because patients had continued disease activity. Infections with vedolizumab in UC and Crohn's disease trials combined, and you see they are virtually identical in terms of infections and serious infections between Entyvio, vedolizumab, and placebo. So it's really carries the impression that this gut selectivity really does carry out to reduce toxicity, particularly in infections. If you look at all the trials combined, and this is basically has a signal in all the studies, the only thing that seems to be consistent is that patients treated with vedolizumab more frequently have nasopharyngitis. Maybe there are a couple MAdCAM receptors in the upper respiratory tract. Nasopharyngitis, but not pneumonias, and this is generally, as you can imagine, not a reason to stop therapy. So it really appears to be remarkably safe. So, in terms of safety issues, how does this play out into what we actually do with our patients? There's no recommendation to test for TB at baseline, whether it's a PPD or quantiferon gold. There's no baseline measurement of hepatitis B recommended. There's no baseline JC antibody measurement required. So this, I think, all speaks to the fact that its gut selectivity really does carry out into clinical practice. Should it be used with thiopurines? Well, we all have sort of, I think, come on board that combination therapy with the anti-TNFs and thiopurines are a real incremental benefit. How about, does that hold out into vedolizumab? So there's been no combination SONIC-like trial with vedolizumab, but in the vedo trials, the sponsor were able to measure drug levels and antibodies. It's not a Prometheus available test, at least not yet. And they found that 11% of patients in the trials developed autoantibodies, and those patients who had antibodies, anti-drug antibodies on 2 consecutive measurements, none of those patients maintained their response. So if you develop antibodies, as with the anti-TNFs, it's a bad thing. Interestingly, and patients were allowed to come in on the study on thiopurines, although it couldn't be added, no patients on concomitant thiopurines developed antibodies, from which I conclude if you're on thiopurines, you'll block antibodies, you're more likely to get a clinical response sustained. Furthermore, I wouldn't expect increased toxicity probably with vedolizumab and thiopurines, as we worry about in terms of combination anti-TNFs and thiopurines in terms of infections and lymphoma, and particularly in young males hepatosplenic T-cell lymphoma. There is not there's no signal whatsoever that I'm aware of in terms of lymphoma, and we already looked at the infection data. Lastly, a few words about use to Kinyuen Lab. Again, the word is Talero, available for psoriasis. Pivotal trials in phase 3. This is already published several years ago. The primary endpoint was a clinical response at week 6. It did hit its endpoints looking at various dosing levels. Clinical remission was an important secondary endpoint, and there too, there was a statistically significant and I think a clinically meaningful difference between the drugs. Open label, this is presented this year from a national-wide group. This was open label study of over 130 patients, and basically it replicated what was seen in the trials, and that is patients, about 2/3 of them had a clinical response. And the most important predictor of who's going to maintain that response was if you were on concomitant immunomodulators, consistent with the stories we see with anti-TNFs, and in fact probably with vedolizumab. So take-home messages. We know that there's still significant unmet need in both UC and Crohn's, even in the age of our remarkably effective anti-TNF therapy. Vedolizumab is effective in UC for induction and maintenance. It has a slower onset of action in Crohn's disease. It's effective for maintenance, and maybe we should use it with steroids to perhaps jumpstart it in Crohn's disease. Waiting for a response might take a little longer with vedolizumab. We've looked at excellent safety profile. Positioning as first-line therapy is still an evolution for ulcerative colitis. The data approaches perhaps some of the anti-TNFs, but again, the safety profile might compensate for that. And in Crohn's disease, I think if we need a quick fix, vedolizumab is not going to fill that role, but perhaps steroids as a jump start before looking for the longer-term maintenance effect of vedolizumab. Thank you very much.